Good afternoon and welcome to the symposium sponsored by Curea. My name is Sebastian Probst and I'm a full professor of tissue viability and wound care at the University of Applied Sciences and Arts, Western Switzerland, Geneva, Switzerland. And I'm the current president of EWMA. I have the pleasure to chair this symposium. I want to invite you now to follow a roundtable discussion on the clinical important subject on exudate management, time to rethink and change the narrative. My guests are Professor Amit Gefen. He is a professor of biomedical engineering from Tel Aviv, Israel, and Professor Bodo Günther. He is a professor and head of the tissue viability clinic, Stord General Hospital in Norway. And now I would like to invite the panel to discuss the first topic on the importance of exudate management. According to you, what decision criteria are for an ideal clinical tool for exudate management, what you use in clinical practice, what is important for you?
Exudates are physiological. They fulfill a physiological role. Exudates is a phenomenon that takes place whenever there is tissue damage of any source, and the body is basically recruiting the troops, the soldiers, to find out what is the cause for the damage, and then to prepare the ground for repairing the damage. And these troops, these soldiers of the body, are the white blood cells. And the white blood cells are naturally in the circulation, in the blood. And for them to leave the blood circulation and migrate to the wound, they need to cross the vessels of the circulation. They need to cross these blood vessels, which they do in a process that is called extravasation. And that process basically means that the blood vessel walls relax a little bit, dilate a little bit, and then these cells can crawl through the walls and then migrate, crawl their way to the tissue damage site, to the wound. But as a byproduct of these, which is again perfectly normal, some fluid escapes from the circulation, and this is basically the exudate as we know it. So it's a plasma-based fluid that contains a variety of proteins, and the cocktail of these proteins depends on the person, their health status, and the wound. But all these ingredients should, in a normal scenario, fulfill a physiological process of removing the damaged tissue and preparing the ground for depositing new tissue in the healing process. So the exudate needs to be there. It's not something that you want to get rid of. And that exudate in its clinical manifestation is what we call the moisture of the wound, the fluid that is covering the wound bed, which have many different roles, and I've listed them here in this slide. It's first of all serving as the medium for the food, the nutrition to the cells, and without cells there's no healing. But it's also a means of communication. This is how cells send signals to each other. And these signals, which are molecules, are transferred through these fluids. And it's also something that allows the cells to move, because cells migrate in a wet or a moist environment. And with that said, it's like everything else in life. You need just the right amount of it, not too little, nor too much. Because if you have too much, which is the other side of the coin, then phenomena such as maceration of the skin, spread of infections, irritation, all the bad things that can deteriorate a wound may happen. So Goldilocks rule, just the right amount, not too little nor too much. And basically the short answer to your question is good exudate management is to keep that balance between the dryness and the wetness. So having a moist wound environment.
Bodo, when you hear the question, what are the decision criteria for an ideal clinical tool for exudate management? What is your experience? What is your opinion?
So what we see quite often when there's inappropriate exudate management, we see, for example, inflammation problems. The exudate often causes more inflammation. So that's one of the things I would look at. Is my dressing decreasing the inflammation problem? And then obviously the peri-wound area, like Amit already said, how is the maceration looking? And then of course I would use healing time. Is the wound diminishing in size as one of the tools to decide, is my dressing appropriate for the exudate problem? So these, and then things like smell, infection, signs of infection. So if I summarize this up, it's inflammation, peri-wound maceration, smell, infections, these sort of things I would use as a tool to determine if I'm using the right exudate management, the right dressing for the wound.
When we are in clinical practice, sometimes I got asked, yeah, how long can this dressing stay on the wound? Because I have the patient has to come back in the outpatient clinic, or I have to plan it. What is your experience?
That's I forgot to mention that, of course, because the wear time is so important.
Exactly.
I mean, we all know for many patients it's painful to change the dressing too often. We have learned that if we change dressings too often, we actually disturb the wound. So in modern wound treatment thinking, we would like to disturb the wound as little as possible, meaning that we would like a tool which we can leave on the wound for a long time, if that's possible. And of course, there's financial aspects to this as well, using resources, having a home care nurse going to the patient to change dressing. We know what that costs. So if you can extend the wear time, there's a huge socio-economic benefit by choosing the right tool.
That leads me to another question. How important is it, this absorption and retention for exudate in these dressings? I think it's also a question to Amit.
Yeah, again, when I look at it as an engineer, absorption and retention are two different things, two different phenomena, despite that they're in our language, they're always used together, but it's important to understand what's the difference. And again, let me share one slide here to visualize it. So think, for example, of foams. And foams is, it's like a maze. If you look at it under a microscope, there are voids there, and there are little channels that connect these voids. And fluid flows through these voids in a completely, say, the ability of the structure to keep those fluids in is completely passive. So it depends on the external configuration, such as gravity, and where gravity is pulling the fluid, maybe capillary action if it's there, but there is no there is no active mechanism that keeps the fluid inside. So the flow, the inflow of the fluid inwards, that's the absorption. The retention is the ability of the dressing or the dressing material to maintain that fluid internally and to not lose it to the environment or to not return into the environment, even if things happen in the environment, such as forces are applying there, somebody's squishing the dressing, or the dressing is hitting something. or any other scenario that can happen in real life, including just repositioning of the patient, which means that he's lying on their dressing. So this is the essential difference between absorption and retention. And now that we understand these two terms, it's critical that a dressing both absorbs and is able to maintain or is able to provide good retention. So it's not enough that you have taken the fluid, it's also vital that you keep it inside, and so that it doesn't spill over, particularly not back to the wound or to the wound's environment. And here, again, there are fundamental differences between dressing technologies. Those that use passive retention capacity, such as foams, you have this internal space, and if gravity and capillary action work for you, then there is so much that you can take, which is that space within the dressing, as opposed to, for example, superabsorbents, where there is active chemical binding between the fluid and the dressing, or elements in the dressing, which are the superabsorbent particles, and then the ability to retain the fluid, the retention capacity of the dressing is very much amplified. It's much higher than that of foams because of that active chemical binding.
Thank you, Amit, for this explanation. You were talking about foam dressings and superabsorbent dressings. Can a right superabsorbent dressing replace a foam dressing? Because you were mentioning both. Because this you can hear in clinical practice, but we use mainly superabsorbent dressings because you can leave them longer on the wound, as we were discussing prior.
In my opinion, superabsorbents would, in many cases, be a better alternative than foams because of the active binding of the fluid. So based on work that I've done over the years in my lab on looking at dressing performances, foam dressings, being passive, are very much affected by the orientation of the wound with respect to the line of gravity.
Yeah.
Sometimes that can work for the dressing if the wound is above the dressing, basically, and then the exudate flows naturally to the foam. But then if there's too much of it, there is this limited capacity, you start to see spillovers. A superabsorbent, for example, in this case, with its much higher capacity, would take much more before that may even start to happen. And that's just one example. So it's not necessarily that the wound needs to be very highly exuding. It's also the configuration and the patient conditions that in many cases will lead to preference of using a superabsorbent dressing.
Mm-hmm. Thank you, Amit. I would like to go back to you, Bodo. What is your opinion about foam dressings and superabsorbent dressings? What are you using in your clinical practice?
Well, in low to moderate exudate cases, we quite often use foam dressings, and then looking at moderate to highly exudating wounds, we routinely use superabsorbent dressings. But I just want to say something about the absorption and retention phenomena. You know, to make it very clear to our listeners, if you can have something that absorbs fantastically well, let's say you take kitchen paper towel, you know, they absorb perfectly, but they don't retain very much at all. That's the extreme example. So there's a lot of dressings out there which absorb fairly well, but are poor at retaining. And ideally, we like to use products which not only retain it, but also move it quite far away from the inner surface of the dressing, to really lock it in the dressing far away from the wound bed. But I think in our practice, if you look at all the patients, I think we use, in half of the cases, we use superabsorbent dressings, and then in the cases with lower exudate, we use foam dressings. And we have to remember, we also have the wounds which are quite deep. I mean, these superabsorbent dressings, they tend to conform to the wound bed somehow. When they fill up, they sort of conform to the wound bed to a certain degree. But if you have a very deep wound, you will have to use some sort of filling material, and then you could combine a foam inside there and as a wick, but it has to be a special type of foam because it has to transport the fluid through it to the super adherent dressing. You would have to have some sort of fill material. Yeah, but in my experience, there is very few foam dressings that can compete with a true superabsorbent dressing if there's high exudate. And especially, we're going to talk about the viscosity of exudate later, but that's another topic, of course. Not all foam dressings can handle highly viscous exudate.
Exactly. This is also my experience in clinical practice. That's why we changed mostly to superabsorbent dressings, especially when we have our patients with the venous leg ulcers, when we have compression therapy. We try to not that the wound exudate goes over the wound edges and causes maceration. When we talk about peri-wound moisture exposure, how important is it to minimize the peri-wound moisture exposure? What is your opinion?
First of all, as I've explained before, exudates do have their physiological role, but they contain many elements to fulfill different requirements that are required at different phases of the healing. Mm-hmm. For example, one of the things that exudates contain is proteolytic enzymes, quite strong enzymes that basically have the role to disintegrate or dissolve the damaged tissue so that new collagen can be deposited over it and form scar tissue. The problem is when a wound turns into a chronic wound, which can happen for different reasons, and then it's kind of stuck in this chronicity phase where the body systems still think that there is a need to keep on dissolving the dead tissue where there's no necessarily such need. You don't want those proteolytic enzymes, and when they're there, they can be damaging to the wound itself and to the environment of the wound. And also, especially in infected wounds, you may have these very odd or abnormal pH levels, very acidic, or sometimes alkaline, which is totally unnatural for the body environment. And again, if you have overexposure to these conditions, that affects many biological systems that depend on an accurate pH balance. And we know from my mechanobiology work that, for example, cell migration is very sensitive to the pH level. So all that movement of fibroblasts that you require to get the fibroblasts into their site and then make them start synthesizing collagen, that would not happen unless you have the right pH environment. And again, if you have this wrong exudate, that is not conducive to the healing process. And we can go on and on, but perhaps the most important point is that the wetness itself is affecting the structure of the skin. And that happens at all levels. There are complicated and sophisticated interlocking mechanisms between the layers of the skin. They're highly weakened when there is overexposure to exudate or to any other fluid, by the way. That can be water for the sake of the matter. The upper layer of the skin, which is stratum corneum, is highly affected. by wetness, and since that's what you have in the surrounding of the wound, in the periwound skin, and you want to protect that, any exudate that leaves the space of the wound and migrates to the wound environment can be detrimental to the healing.
Yes, I find this is a good panel because we have this scientific side from it, and Amit always has great slides to build up under these theories, and so I'm very happy to be in this group actually because I see it's going to be useful. Yeah, the periwound area. I mean, I see the periwound area as my friend. We have to take care of it because eventually, once the wound bed has granulated, most of the cells, the skin cells will migrate over. So we have to take care of them. And not only, if you have continuous exudate problem, it will not only force these cells at the skin edge to go into a sort of state of hibernation, you know, like a bear in wintertime sleeping throughout winter. But as you know, Sebastian, from your own practice, in, like, for example, venous ulcers, when there's a lot of exudate, the skin breaks down at a surprising speed. Suddenly you have an ulcer twice the size, only due to the fact that exudate management wasn't handled properly.
I like the expression to handle the periwound area as a friend. So we have to take care of him so that we do not have a skin breakdown. One last question for this part for both of you. Are there clinical gains in binding bacteria and MMPs inside the dressings? Amit?
Well, obviously, yes. And the thing is that this is something that only an active binding mechanism or dressing containing an active binding mechanism can do. So again, going to the example of the passive form structure, and again, there may be good absorption, but in many cases there could be backflow of exudate with everything that it contains, all these proteolytic enzymes that I've mentioned, or any pathogens that are there. Whereas if you lock the fluid in the dressing, and as Bodo said, desirably far away from the wound bed, or as far as possible from the wound bed, it is a limited space there, but as far as possible, then you basically help mitigate that process of a high concentration of proteolytic enzymes being present in the wound, or a very rich and flourishing population of pathogens proliferating in the wound, and you have this active mechanism that mitigates that, but by attracting and locking all these undesirable elements away from the wound bed.
I think Amit said most of the points here. I mean, like he said, obviously, yes. I think maybe not all listeners are completely aware what metalloproteinases actually are. I mean, obviously, they are something natural and the wound needs them, but it's all about balance, and we don't want to sterilize the wound concerning bacteria either, but there also we want a balance. We want to have a nice balance of bacteria and of metalloproteinases and keep them at a fairly low level. And like I said earlier, when I look at my choice of superabsorbent dressing, I like a dressing which locks these two things, both bacteria and MMPs, far away from the wound surface, nicely locked inside in the center of the dressing. Because some dressings maybe lock them away, but there's still some sort of dampness at the inner layer of the dressing, so that it doesn't lock them far away from the wound surface.
Thank you. I would like to close this part and go over to the next part that is named a novel robotic phantom study on absorption and retention of exudate. Amit, please.
Over the years, we have developed different versions of what we call robotic wounds or robotic phantom systems that simulate wounds. And what I'm showing here is one of the latest versions that we have developed. Basically, we create a wound simulating environment in the lab. And in this case, we create it in duplicates. There are 6 identical wounds here. And these are fully computer controlled. And they do, at least from a physical and engineering perspective, what a wound would do. That is, they secrete exudate. You can see that, of course, in exaggerated amounts here, but we can control precisely how much exudate they would secrete through an irrigation system that they have in the cavity shape of the wounds that we're creating. They're made of soft materials that we have specifically created so that they look and feel like real soft tissues, skin and underlying tissues. Some of these elements here are 3D printed or can be 3D printed. So basically we can form different shapes and sizes of the wounds. And as I said, everything is controlled by automated systems that allows to adjust the flow rate into the wound, the flow, the total volume of the exudate that is transferred to the wound at a certain time period. And we also control some of the important physical or biophysical properties of the fluid itself. So it's not just water or saline solution or ringer solutions or one of these watery solutions that are often used in dressing tests. This is a liquid that we have formed based on food ingredients, by the way, so you can eat it or drink it. But what's interesting about it is that its viscosity is adjustable and can be controlled and simulate that that range of viscosities that you see in actual real life wounds. And there are other parameters of the fluid that are also manageable or can be adjusted, such as the pH of the fluid and even the color of the fluid. So basically we control everything here. The temperature, of course, which I did not mention. We can have pieces added that simulate necrotic tissue into the wound. And that's a wonderful platform for doing experiments that are indicative of the performances of any existing or possibly new wound dressing technology, including head-to-head comparisons, technology versus technology comparisons, and real-life considerations. The clinically relevant considerations are very strong here. You can account for the technique of application of the dressing or more than one dressing. For example, if you have a primary and a secondary dressing, which is not our case here, but in concept, you can take all these clinical factors into account, including the position of the wound with respect to the dressing and the forces. So you can, for example, look at non-offloaded wounds versus offloaded wounds or partially loaded wounds. All of that is possible. And just to give you an example, think about now one of these wound simulants as a sacral pressure ulcer. And you can think of positioning that sacral pressure ulcer in a prone position so that it's completely offloaded, both the wound and the dressing. You can think of turning that system upside down and putting weights on it to the extent that stimulates the body part, the body mass at that specific anatomical region. So, for example, now putting that wound in a supine position, which is something that you would typically not do unless you have no other choice from a clinical perspective, such as if you need to ventilate that patient when they are supine. And so you make that compromise, okay, let them basically lie on their pressure ulcer, but we need to get some oxygen into their lungs. Or you can think of any other body position, which you can simulate with the systems. And the important and interesting thing is that the orientation of the gravity vector with respect to the wound and the dressing would matter a lot. So think about, again, a dressing that needs to work against gravity, which is basically the fluid needing to climb up from the wound, from the bottom of the wound cavity in the prone position and climb its way up to the dressing, versus gravity working with the wound and with the dressing, so that the exudate basically drips from the bottom of the wound, from the cavity to the dressing when the patient is supine. These are two, from an engineering or from a fluid mechanics point of view, two different problems that the dressing needs to handle, and it's typically the same dressing that needs to provide these clinical solution and the clinical performances in both ways. Now think of what I'm calling the ultimate challenge for a dressing, the side-lying position, where due to gravity, and this is illustrated at the bottom part of the slide, due to gravity, the dressing cannot use its entire effective surface area because the fluid tend to concentrate in just one spot, the bottom of the the bottom of that configuration where the gravity is pushing it. So all of that can be studied and simulated. And now you can look at different dressings. And here we compare the curea P1 dressing to another commercially dominant superabsorbent dressing, and also to another popular foam dressing. So again, one product against another in the same or under the same family of products, or different product technologies. And we have put them into these simulated wounds in the robotic phantom. Over time, so you see we have 3 time points where we've tested each dressing after 12 hours, 24 hours, and 30 hours, looking at basically how much fluid we found in one of the following sites. In the dressing, which is the bottom part of the bar with the little dressing mark on it. In the cavity, where this is the drop symbol, in the cavity of the wound, where obviously you want to find as little fluid as possible. Evaporated to the environment, which is the top part of all these bars. Or in some cases, what you really don't want to see, spillover, which appears on the right-hand side, the bar at the most right-hand side. And this is for 2 experimental conditions here. Low viscosity exudate versus high viscosity exudate. And again, it's really important to understand that most of the testing so far has been done on watery solutions containing combinations of salts, but very little work has been done on high viscosity fluids, which dressings in real clinical practice need to handle. And first of all, you see totally different results, performances depending on the level of viscosity of the exudate substitute. The other thing that you see is that even within the same viscosity level and for the same dressing technology that is superabsorbents, the 2 products, which are both, again, superabsorbents or both contain superabsorbent particles, grains, behave very differently. If you look, for example, at even at the low viscosity exudate data, the curea is constantly increasing the fluid portion that is contained in the dressing. You see that arrow climbing up on the left-hand side of the slide, whereas the other dressing does not show that. And since both of you, Sebastian and Bodo, know better than me that a dressing stays on a patient for something like 3 to 5 days, 30 hours is starting to be a clinically realistic time frame. And what you want to see at that point is little fluid in the cavity and most of the fluid in the dressing. So not all superabsorbent dressings are born equal in this regard. Each one of them, with their own characteristics, materials, and composition, have their own performances depending on the specific composition and design. Now, if you compare that against foams, the differences are even more remarkable. And you can see, for example, now let's go to the extreme, high viscosity, and over time, you can see that, as I've indicated already in the beginning of our discussion, the foam cannot uptake enough of the fluid, and some of it, after a certain amount of time, 30 hours in this case, just spills over, and it will reach the periwound skin and may cause damage there. And what I like to show most is this slide, which is the ultimate test for the dressings. Something that simulates side lying, where gravity is pushing the fluid to one region, obviously the bottom region, in the dressing, basically not allowing the dressing to utilize its entire effective wound pad and its entire reservoir for handling fluids. Now, this is where you see huge differences in performances, both for the two superabsorbent products against each other and between the superabsorbents and the foams. You can see that because we're just using here a limited capacity of the dressing, first of all, that binding concept is becoming very important. So fluid is being locked inside in the superabsorbents, but not in the foam. So when the foam is reaching its very limited capacity here, you see a huge spillover of fluid to the surroundings. Even between the superabsorbents, there is a different, again, associated with the different structure and composition and specific layout of the materials in the dressing, again showing that in such a challenge, which is not so unique in a clinical scenario, that you have to place a patient with a wound lying on the side. That's something very common, but still these two dressings respond so differently. And I think that basically this slide is saying it all. Superabsorbent dressings are not all equal. They're different, much like in any other dressing family. I could say the same thing about foams. It all depends on the microstructure, microcomposition, and macrostructure and macrocomposition, ranging from the microscopic architecture of the materials to the manufacturing technique. And all of these combination of factors will eventually determine a specific performance metrics. And you see these, how different these performance metrics could be in this slide here.
Now, I will come back to the panel and discuss this question a little bit. Are all superabsorbent dressings more or less the same? We've heard already a part from Amit, and what does it mean to be fit for purpose absorbent dressing? I would like to go directly to Bodo. What is your experience in clinical practice?
Thank you. And thank you very much, Amit, for your excellent simulation research. It's very interesting. And you have to do it in a simulation because it's not possible to do it in humans. It would be a really big task. So, but very interesting. Yes, back to your question, Sebastian. I'm the sort of person who likes to try all sorts of dressing. I'm quite lucky because at my clinic, I'm allowed to purchase different products, and I like to try out a lot of products. So I feel very comfortable to say that I've tried most. And as Amit already has shown, there are very big differences. If you look at the product category, superabsorbent dressings, there are huge differences, not only in the way they absorb and hold moisture, But you've also got other aspects like viscosity. How well do they absorb thick viscous fluid? How are they adhesive to the wound bed? Do they stick to the wound bed when you change the dressing? How do they perform under compression therapy?
Excellent. Thank you. You were talking about viscosity, and how does the viscosity of the exudate affect the technology, and how does the typical process of testing superabsorbent translate into the real world?
The ability of a protein-rich fluid to penetrate a porous structure such as a dressing depends highly on the specific content and composition of these proteins. So it's not just the speed by which it moves, it's also the permeability that they have in penetrating the porous structure and how fast they spread within this porous structure. Now, dressings in general, modern advanced dressings, superabsorbent dressings as well, tend to have multiple layers. And so for the exudate to reach the core of the dressing in a superabsorbent dressing and be locked there, you need to cross several, you could say, barriers, which are these different layers in the dressing. And the ability of the fluid to cross these different layers in order to reach the core of the dressing and be locked there in the superabsorbent element will depend on the viscosity, which is basically the speed by which it is able to flow, and the porosity and connectivity, which is essentially how much, how many routes, how many alternative routes this fluid may have in order to reach their target. Because if it has too little, then it's a traffic jam, much like what happens in roads. And if you have many of these routes and speedy cars, which are less viscous fluids, then the traffic is becoming faster. You can think about it in the sense of that analog.
Thank you. Amit, Bodo, yes, please.
Yeah, I agree. If you want to test the dressing, use viscous fluids. And I saw it on one of your slides, Amit, there was also the question of pathogens in the viscous fluid, because what we often see when there's this thick, slimy, viscous fluid, it often contains much more pathogens than the thinner fluid. And anaerobic bacteria, they really like this thick, slimy material, and Pseudomonas as well. So it is very important to get this away from the wound.
Thank you. This leads me to the next question. What are the key differences with the superabsorbent technologies, and how do those differences benefit the patient?
So if I can first take that question first, Sebastian.
Yes, please, Amit.
Then again, I'd like to show a slide. Now, what I'm showing here basically is two or the two popular superabsorbent structures that are available in commercial superabsorbent dressings. And again, you would not be surprised that there is this financial consideration in how you produce a superabsorbent dressing. So superabsorbent, the heart of a superabsorbent dressing is these superabsorbent particles, typically made of sodium polyacrylate. And these are the grains that absorb the fluid. And once they absorb the fluid, they swell, and they swell substantially, reaching volumes that are much higher than their original volume. And so the simplest thing, and obviously the cheapest thing that you can do, is to basically put them in an envelope and say, hey, now I have a dressing. It has the two walls or two covers in between those the superabsorbent particles are contained. But the problem with this is, although it's probably the cheapest way of producing dressings, is that once these superabsorbent particles start to swell as they're exposed to fluid, they start to apply pressure on the envelope, on the walls of the dressing, and they don't have anywhere to escape because they're all packed internally in the dressing structure. So they're pushing against each other. And it's not only now the individual grains that are increasing in volume, it's also the whole core that is gradually increasing in volume and pushing against its boundaries. And then at some point, this happened, bursting of the dressing. And you can do things about this. You can laminate, you can reinforce, but you will always have this phenomenon of the core overswelling. Now there is another technology for manufacturing superabsorbent dressings, which is on the left-hand side. And in this technology, which is called air-laid technology, this is, by the way, the technology that curea use in their dressings. The grains are not touching each other. They're spread in a controlled manner within a fluff. And so there is some space between one grain to another. And so when they are exposed to moisture and to the fluid, they still swell. But as you can see on the left-hand side, bottom part of the slide, they still don't push against each other because they have that extra space to swell.
Thank you, Amit. Bodo, would you like to add something?
I just a little bit. I think Amit said most of it already, but you'd also like to have as thin as possible. If you can make a superabsorbent dressing which is very thin, this is usually an advantage, both if the patient has to lie on it or if you have it on a compression dressing. And some of these superabsorbent dressings like curea, they are very thin, surprisingly thin.
Mm-hmm. Mm-hmm. Thank you. When you're in clinical practice and you suggest some wound dressings and you suggest a superabsorbent dressing, you hear very, very often that the colleagues, they say, oh, yeah, superabsorbent dressing, that's only for high exudating wounds. What is your opinion, Bodo?
Yes, that's a myth that many people think is
exactly.
And as we know, you can actually use superabsorbent dressing on a wound with low exudate. Mm-hmm. It will not dry out this wound because it only takes the excess of the exudate. So if there's little exudate, it'll absorb little.
It's exactly this. It's still this myth in here in clinical practice that think, oh no, low exudating wounds, we cannot use superabsorbent wound dressings.
Also the reason why we have a low threshold, when we're a bit unsure, then we can safely choose a superabsorbent dressing, even if we think maybe there's not, we don't always know exactly unless we see the old dressing. We're not always completely sure how much exudate there is. In my clinic, often I get called to the tissue viability clinic, and somebody's already taken off the old dressing and thrown it away, and I haven't seen it, and then I have sort of to make an educated guess how much exudate there might be. And so it's always it's a safe choice to choose superabsorbent dressing, even if you're not quite sure if there's really a need for it.
Exactly. This is exactly my experience.